Hi everybody, I'm Ashwin
I'm Raj.
and this is Blood Cancer Talks. This podcast is exclusively dedicated to hematologic malignancies where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today we are excited to discuss about two new clinical trials which are recently presented at American Society of Hematology annual meeting in San Diego in December of 2023. We have an expert, Dr. Tefferi, who's a regular guest in our podcast. And thank you so much, Dr. Tefferi, for all your insights. Dr. Tefferi is a professor of medicine, Division of Hematology, Department of Internal Medicine, Mayo Clinic, Rochester. Dr. Tefferi, thank you so much once again for joining us. Before we start, maybe a brief introduction about you and your clinical and research focus.
Oh, absolutely. And thank you again for having me. And I totally enjoyed this podcast. As you all know, I am a professor of medicine here at the Mayo Clinic and have been here since, believe it or not, 1986. That's when I came here to do my fellowship in hematology. So I'm kind of approaching the 40 years anniversary here, and Rochester has changed a lot. Primarily, my interest is in myeloid neoplasms. I do all of them, but my special interest is in chronic myeloid neoplasms. That include myeloproliferatives, myelodysplastic, overlaps, mastocytosis, eosinophilia, and the like. And primarily, I see patients. I have been doing that for many, many years, and I'm not going to stop doing that. I usually spend about 2 days at clinic every week, and then do the rest, research and what have you. Lots of education, lots of speaking nationally and internationally. I never say no to fellows or students inviting me. I often say no to pharmaceutical companies inviting me, but not academic institutions. That's why I really like this podcast, and I'm very happy to share my views on all the subject matters that are relevant.
Thank you. Thank you so much, Dr. Tefferi. So, this episode, we will start with a case and then we'll briefly review what are the current challenges. Then we will talk about the two clinical trials that were presented. One is Transform 1 and other one is Manifest 2. I think those are two clinical trials we want to discuss today. So the case which I saw in the clinic is a 65-year-old male with no significant past medical history, presented with fatigue, occasional night sweats, pruritus, unintentional weight loss, and poor appetite for the past 6 months. A review of his complete blood count showed that WBC count of 8.1, hemoglobin of 10.8, and a platelet count of 122,000. On exam, patient showed to have a splenomegaly. Given these findings, patient had a bone marrow aspiration and biopsy, which demonstrated hypercellular marrow with megakaryocyte proliferation and atypia with reticulin fibrosis. The WHO grading is MF2. With a normal karyotype, myeloid NGS panel show JAK2 V617F mutation with a variant allele frequency of 23% and a SRSF2 mutation with a variant allele frequency of 20%. So given this patient who's in the clinic right now, so Dr. Tefferi, can you walk us through how would you approach a case like this who's likely a new diagnosis of primary myelofibrosis, who has, according to your risk scoring system, he likely has a high risk myelofibrosis?
So this is a 61-year-old gentleman.
Correct.
And so he's young.
Mm-hmm.
And he comes with anemia, but not yet transfusion dependent, but hemoglobin of below 10. And a bone marrow examination confirmed the clinically suspected diagnosis of myelofibrosis. So the first thing I look for whenever I see patients is what is the genetics background. That's the most important thing. Obviously, I see the patient. The patient looks good, 61, but it's got some symptoms. That's why he came to the hospital. So the first thing I want to know are what are the genetics? That's the key. So I want to know what the cytogenetics show. That's the most important element here for prognostication is the cytogenetics. And I would not hear that we couldn't do the cytogenetics because the bone marrow aspirate was dry. That's not a good excuse. You could do cytogenetics in the peripheral blood. You can do expanded FISH. You can find out what kind of cytogenetic abnormality. And it is the most important prognostic parameter. The second most important is the next generation sequencing to see if the patient has high molecular risk mutations. Those are the most important. In fact, if you just told me those, I have a genetics only risk stratification called GIPSS, and I can tell you exactly how that patient is going to do and whether or not that patient should go to transplant sooner than later. So that would be the first thing I would do. Could you tell me, Ashwin, what the cytogenetics and what the high molecular risk mutation results showed?
So the patient had a normal 46XY, and the myeloid NGS panel showed a JAK2 with a variant allele frequency of 23% and a SRSF2 mutation with a variant allele frequency of 20%.
Very good. So therefore, the patient, number one, does not have the blessing of having a type 1 CALR mutation. Because that would have been a wonderful thing. He doesn't, which means as soon as the patient lacks the type 1 CALR, already down by 2 points. In the MIPS version 2 score, if you don't have a type 1 CALR mutation, you're already starting at -2. Now, on top of that, the patient has a high molecular risk mutation, which is SRSF2. That gives him another 2 points. Fortunately, he only had one. He had two, it would be 3. So SRSF2 plus not having CALR already puts him at 4 risk. And he does have anemia. Depending on the severity, it's either 1 or 2 points, which means he's already high or very high risk. This patient has no business dealing with drug therapy. Such patients, young, 61, should immediately be referred to the allogeneic stem cell colleagues. Transplant consult is the first thing that I would do. These patients, if your objective is to let this patient live to be 80, rather than treat the anemia or the spleen, if that is your objective, the immediate thing you should do is this is a high or very high risk group patient, and he has to see transplant consultation, and transplant should be done as soon as possible, period. That's number one. Then you say, okay, the transplant referral is done. Now the question is, do I need to do anything in between? And that depends on the degree of symptoms. Number one, you told me he's anemic. What was his hemoglobin again, Ashwin?
10.8.
That's not severe at all. That's kind of mild to moderate for a man. For a woman, that would have been just mild. So I'm not interested in treating the anemia. I'd rather wait for the transplant consultation, number one. Number two, how about the spleen? How big is it? How many centimeters below can you feel it in your hands? I don't care about the imaging. I have hands.
8 centimeters below.
Acceptable. 8 centimeters is not a big spleen. And this is a patient that can go to transplant. Usually they like it to be less than 15 centimeters. My transplant colleagues like it to be even less than 10 centimeters, and that's fine. But this patient does not have a big spleen, and therefore I don't need to treat the spleen. Therefore, again, I will wait for the transplant consultation. The third and final thing, how symptomatic is he? Can he live with himself? In other words, yes, he could have a little bit of night sweats. He might be tired. He might be losing some lean body mass weight, but can he live with himself? Is he otherwise okay? Or is he sick like a dog?
So he was severely symptomatic for the past 6 months. He thought that this was something related to his work and he didn't seek any medical attention. But now he's seeking medical attention and is symptomatic with profuse night sweats as well as pruritus and weight loss.
Therefore, there is a clear indication to treat while we wait for the transplant consultation. The question now then is, what are we going to use? Now, unfortunately, we have several options for anemia. We have several options for spleen. But for symptoms, catabolic symptoms, hypercatabolic symptoms like this, usually these are very refractory to hydroxyurea or other ordinary traditional cytoreductive agents, and they're only responsive to JAK2 inhibitors. So this is the place where JAK2 inhibitors are probably the first thing to use rather than hydroxyurea. Hydroxyurea is not going to help him much with his constitutional symptoms. Then comes the hard question, which one? Mm-hmm. Because we now have 4 that are FDA approved, okay? So which one would you use? Now, you have to remember this. This world is not a scientifically logical world. This world is made up of small fiefdoms everywhere with different groups having their own drugs, okay? This is the reality. So nobody is going to argue here, or you should give this, or you should give that. All I'm going to tell you is what I would do. In this kind of situation, I would start the patient with something that will help his symptoms without making the anemia worse. Simple. And the only drug that has been shown consistently to do that is momelotinib. I have had a very extensive experience with momelotinib. And by the way, he doesn't have a very big spleen. So I start with low-dose momelotinib. I'll give him 100 milligrams of momelotinib and see how he does. This way, I would reduce or minimize the risk of peripheral neuropathy or other issues, or even thrombocytopenias that might also come up with momelotinib. So I would go with 100 milligrams. And if he responds beautifully, then we will wait for the transplanter. And that's it. This way, I don't cause much harm, and I'm just waiting. And that's how I would start, and I wait for the transplant. And I'm happy to answer any additional questions you might have, Ashwin, about the case.
So my question is, so let's say that for whatever reason, the patient does not have a good donor options because of his race and all those things. He does not have a good donor. How would you approach a patient like that? Like a group of patients, we cannot find a donor.
Of course. So first of all, to me, there is no such thing as there is no donor. Okay, everybody's got a donor. Everybody's got a donor. Traditionally, we wanted an HLA identical sibling donor, but nowadays we're getting as good results with unrelated, otherwise HLA matched donors, or even haploidentical donors. Therefore, everybody should have a donor because everybody has a brother or children or somebody. So I would not accept there is no donor. Because this is a guy with high molecular risk mutation, SRSF2 mutation, symptomatic. It's only a matter of time before he turns into acute leukemia and dies. There is no option. There is no negotiation here. I would strongly say we need to transplant this person. Now, having said that, Ashwin, let's say that, okay, the patient say, no, I don't want transplant, all right? That's better. I don't want to transplant. Well, then what would I do? Well, I will very respectfully and kindly and compassionately tell the patient that without transplant, that he's going to die, period. Because the patients need to understand the gravity of the situation. You need to tell them. You can't tell them, well, you know, we can use the JAK inhibitors and maybe they can prolong life. No, this is a disservice to the patient. You have to tell him that that's exactly it. If you don't get transplanted, the only thing we can do is try to make your life comfortable until the disease takes its toll. And in that regard, we have many, 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 many drugs, and none of them are curative, and none of them can change the natural history of the disease, but all of them can do something for you, and we will carefully use one after the other until we run out of options. Big question here is it better then to put the patient on a clinical trial? Okay, and I think that's what you're pivoting to. So you've got all the drugs that are available, and then you have this additional clinical trials that are mostly an add-on to Ruxolitinib. And so the question you ask me is, would you put your patients on clinical trials? Of course, I will like to put the patients on a clinical trial with the hope of doing better than what I have. But if the clinical trial doesn't appeal to me, I ask the question, would I get myself into that clinical trial if I was in the same position? And if my answer is no, 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 I wouldn't. So therefore, why would I put my patients on that clinical trial? Now, let me be a little more specific, Ashwin. This might not be a politically correct way of answering, but I got to answer you. Let's say, for example, that patient is here, and I have all these clinical trials available. And for example, let's say that we have these add-ons, okay? Let's start with the add-ons, because that's what you're going to talk about. So that I have an add-on with Pelabresib. I have an add-on with Navitoclax. I have an add-on with, let's say, Selinexor. Okay, you know, all those add-ons, they're everywhere because there's money to be made here. So then the question is, knowing what I know about these drugs, because that's what you wanted to talk about today, would I put my patient in any of these three drug trials? That's it. I mean, I think that's the gist of this podcast. This is what you want to know. Now, here's the question. The question is, what can you do with these drugs? Can you possibly prolong life? Can you possibly cure the disease? Obviously, we all know the answer, and the answer is no. No, you can't. Now, there's always that spin, as you know, that, well, you know, the allele burden went down, and therefore, there is a chance. Spin number one. Spin number two, study is done. Time to retrospectively massage the data to make it look better than it is. Spin number two. And what is lost here is the fact that someone who's biologically destined to do very well in life with this disease, live long, not necessarily get anything, are going to be the same person who's going to stay on the drug because they're going to live longer. And so this treatment selection bias is flagrant and very vulnerable for spin. And we've seen that with interferon treatment for polycythemia vera. Now we're seeing it also with Ruxolitinib in polycythemia vera, you know, the so-called magic PV studies and so forth. All this retrospective messaging of the data and comparing responders and non-responders. I was in medical school and I was told that you never compare responders and non-responders because it has have nothing to do with the drug. It all has to do with the selection of patients who are going to do well anyway. So therefore, do I believe that any of these drugs, minus this spin, would actually change the natural history of the disease? I don't. Absolutely not. Nobody has shown me a cytogenetic remission, okay? Yeah, you can tell me that the JAK2 burden went from 40 to 30%. Good for you. Show me cytogenetic remission. Show me externally validated morphologic remission. Then we can talk about natural history. There is no myeloid neoplasm under the sun that went into prolongation of life without these nuclear changes, I would call them, with cytogenetics and morphology. Every disease, whether it's CML, APL, or anything, it has to be accompanied by cytogenetics. So these drugs are not going to cure the disease, number one. So then the question is, well, if they're not going to cure the disease, if they're not going to prolong, if the likelihood is very low, then why would I treat this patient? Well, to make them feel better. Oh, very good. I agree. So if I can give that patient 100 milligrams, not cause problems, and make them feel better, why do I need to shrink the spleen from 30 centimeters to 5 centimeters if the patient can live happily ever after with just 10 centimeters, okay? And allowing the patient to continue to take the drug because you will less likely have toxicities from the higher dose of the drug. In other words, the way I think is very simple. If the objective is to provide palliation, comfort, until something better comes, then the goal should be to make sure that the patient stays on the drug, not discontinue the drug because of side effects. And any drug, the higher dose, the more likelihood for side effects to occur. That's how I look at this. So when I look at these drugs, these 3 drugs, let me start with the easy one, Selinexor. All right, my patient is doing very well. Now, all of a sudden, why do I want him to be nauseated? Okay, like almost everybody gets, and then thrombocytopenic and everything, because I can shrink the spleen further. Why do I want that? Neuropathy and also things. It's out. I'm not interested. Okay, I'm not interested. I'm not here to serve the drug companies approve their drugs. I'm here to do the right thing for the patients. Let's go to the next drug. The next drug will be Navitoclax, another nasty drug. Okay.
So, Dr. Tefferi, do you want to talk about the data as well, just so that for our listeners who might not be well versed with the data?
Oh, absolutely, absolutely,
okay.
Absolutely. If you remember, the Navitoclax is a transform trial, and that is where Navitoclax was added to Ruxolitinib and compared to Ruxolitinib plus placebo. Okay, that's the transform trial. And in this trial, they were able to show that the people who got the Navitoclax plus Ruxolitinib has had a spleen reduction that is twice as much. In other words, the spleen response, 35% spleen response, was around 60 to 65%, as opposed to about 30% in patients that took just Ruxolitinib with placebo. The other drug, the Manifest-2, it's the same design, except the drug here is Pelabresib instead of Navitoclax. And again, the response is very similar, 66% versus around 30, 35%, okay? So in both these trials, the spleen response with the addition of either Navitoclax in the Transform trial or Pelabresib in the Manifest-2 trial was twice as much as what you could see with just Ruxolitinib. By the way, Selinexor also gives you that degree of response. Now, then the question is, okay, if you give me that kind of benefit, then I ask you, how much money do you want for it? Okay, what's the cost? What will it cost me? Obviously, financially, it's going to cost a lot, but we're not going to talk about that. We're not going to talk about that. So what is it going to cost me? Well, let's take Navitoclax, for example. First of all, a third of the patients discontinued treatment. Okay, it's about a year to a year and a half follow-up. A third of the patients already discontinued. Now, these patients were good-looking people. They had grade 3 thrombocytopenia, was about half of the patients. and then almost 40% got grade 3 neutropenia. Okay, that's usually not seen with JAK inhibitors. So a significant amount of side effects, no difference in symptom palliation, and the only thing you got is spleen. So then I ask, is that a fair? Is that a fair exchange? Absolutely not.
On that, Dr. Tefferi, I just had one question.
Sure.
Just for our listeners, we hear all the time about Venetoclax for management of AML. How is Navitoclax different than Venetoclax?
Well, supposedly, it inhibits a broader range of the BCL molecules, okay? And now the Navitoclax targets BCL2, as you know, right?
Mm-hmm.
Now, this is supposed to also inhibit BCL-XL and the other members. And supposedly, the laboratory studies have suggested that there might be more of the BCL-XL rather than the BCL2 in the context of myelofibrosis or myeloproliferative neoplasms. That was the rationale.
One other question while we are on SVR35, where both Transform 1 as well as Manifest 2 have shown a significant improvement compared to Ruxolitinib alone. There is a point to be raised that of all the endpoints in myelofibrosis clinical trials, SVR35 is the only one correlated with overall survival. I just want to take your take on that. What do you think?
Okay. First of all, I don't know if you remember in Manifest 2, the majority of the patients, almost 60%, were intermediate 1 risk patients. I mean, these were good-looking patients. These are GIPSS intermediate 1. And the Navitoclax actually had a significant number of intermediate 2. In fact, they have a higher risk group than Navitoclax group. But in the Pelabresib group, most of them were intermediate 1. These are good-looking patients. Now, you have to remember, any kind of response is better when you start with better-looking patients. Always. So the first question you should ask is, who are you treating? Is this all high-risk patients? Are you getting this kind of response in high-risk patients? A spleen response is more likely with a 12 centimeter spleen, with a 15 centimeter spleen, than it is for a 25 centimeter spleen or a 30 centimeter spleen. This is very, very important. So if you treat good-looking people, you're going to get better results. Now, why is this important? Because it comes to what you are asking me. Survival. Why it is important is the intermediate 1 risk patients have a very good survival to begin with. It will be very, very difficult to show that with treatment that you can improve survival just based on anemia response or spleen response. Now, obviously, the drug companies and their enablers are not going to sit around and they're going to start calculating stuff. See, statistics allows you to lie if you want to lie. That's the nice thing about statistics, is you can do all sorts of statistical analysis to show that something that you want to show. I mean, that everybody knows about this. So statistical permutations are very notorious. It allows you to tell a story where there isn't one. So therefore, this suggestion that overall response, spleen response, is associated with improved survival, or anemia response is associated with improved survival. We have shown that with momelotinib. We have shown that responders, okay, live longer than non-responders. But I already told you that you don't do that. You don't make responders and non-responders. You do a randomized study from the beginning, and then you show me in a properly controlled, adequately powered randomized study that one arm is better than the other. If you can't, please stop. Don't go start retrospective messaging of data to say, well, this kind of response is associated with this. Now, let me tell you this, another thing. We all know that HMAs prolong life in MDS by 7 months, all right, or by 9 months, or by 1 year. Are you really excited about that? It's exactly the same way. Is even if this was true, and then you have made a survival prolongation which is a statistically significant, all right? Maybe not clinically significant statistic. Are you going to be excited about that? So my answer to you is all this spleen responder is associated with overall survival. All that is a statistical maneuvering to make something better than what it is. And it is not to be attributed to the drug. It is to be attributed to the underlying biology of the patient's disease, which is allowing that patient to respond and live longer. Those are the patients who are going to do well, regardless of whether you gave them the drug or not, whether they responded with the spleen or not. As soon as you start comparing responders and non-responders, you're out of my box. I'm not interested.
Thank you, Dr. Tefferi. I had a quick follow-up question on this before we go to the Pelabresib. So, as you know, as an outsider, I don't treat myelofibrosis, but regarding this clinical trial of Ruxolitinib plus Navitoclax versus Ruxolitinib plus placebo, I understand that overall survival was not the primary or secondary endpoint. But did you guys get any overall survival Kaplan marker showing a trend towards overall survival benefit, or any overall survival data that was presented at ASH, or is it still very immature based on the median follow-up?
None of the studies in myelofibrosis, none of the studies can ever do a proper survival analysis comparison because they're all crossovers. I mean, if you don't treat one, you will usually get the other one, and this one, and so forth and so forth. It's impossible. It's impossible. I mean, it's the same problem we've had with the JAK2 inhibitors. There's a camp that think that you can improve survival, and there's me and the others say, no, that's all a bunch of whatever it is. It isn't. Because you have to remember, I can prolong survival with supportive care. All right? You give me 100 patients with CML, all right? And I treat 50 of them with hydroxyurea, 50 with nothing. Who do you think is going to live longer? The people who get hydroxyurea, because they're not going to die of priapism. Correct? Does this mean hydroxyurea prolongs life? So you have to remember, even supportive care can prevent death. Preventing death from complications is not equal to biological prolongation of life. We have to make a distinction. And so therefore, all these trials in myelofibrosis, the way they're designed, cannot answer that good question. I think that's knocking on the wrong door. What we should do is look at legitimate surrogates of survival, cytogenetic remission, morphologic remission. Why? Because there is a precedence with other myeloid disorders, acute leukemia, myelodysplastic syndrome, CML. With all these diseases, we know that if we can get rid of the cytogenetic, if we can get a morphological complete remission, that survival is prolonged. Maybe not a lot, but a little bit. But unfortunately, here, instead of going for the real deal, everybody's going, well, the spleen response. I mean, does anybody in their sane mind think that the spleen response can prolong life? Come on, what kind of biology is that? It makes no scientific sense. And the question is, if it doesn't make scientific sense, you don't have to force it. You don't have to force yourself to believe something that is not making scientific sense. Obviously, the agenda is marketing. See, you have to remember, all these things are being said and done and debated with an agenda. And the agenda is market, market, market. That's the agenda. Nothing else. I mean, why would you give Ruxolitinib to a patient with ET? And there are now clinical trials in ET with Ruxolitinib. Why? Do you think it's because they want to help patients? Absolutely not. The agenda is how can we expand the market and make more money? Fortunately, I'm at the Mayo Clinic. I don't need anybody's money. I take care of patients. I get paid reasonable salary. I don't need $1 billion. I'm fine. Unfortunately, the world is not the same way. Everybody is interested. I don't know why. I don't know why people are so greedy. You're not going to die with, you die with 1 billion or you die with 1 million. What's the difference? Unfortunately, the whole thing is shifting. And, not everybody is that way. I mean, I can't be so pessimistic about this. But hopefully, if there is a little bit of a constriction on the budget, maybe we might start behaving the right way.
So, Dr. Tefferi, you bring up a lot of interesting points. I think one thing I want to pick your brain is to push the needle in myelofibrosis drug development. What are the correct endpoints in designing a clinical trial, and at what timeline? Would you consider it week 24 or week 48? How would you design an ideal clinical trial for drug development in myelofibrosis?
Well, first you have to identify where is the unmet need. Where is the true unmet need at this point? Disease-modifying agents.
Correct.
Okay. There are now ongoing trials with specific mutant CALR targeting, either by vaccines or monoclonal antibodies. I like that. It's specific. It's not a non-specific, let's hit JAK and see what happens kind of thing. There is a lot of efforts in trying to design a more specific JAK2 inhibitor. You know that. There's a lot of companies working on that, and they're trying to come up with that, and God bless them. It's going to be a tall order. It's very, very difficult. I don't know how they're going to do it. Okay? They will come up with something, but I'm not sure how specific that's going to be. It's a very conserved region. I mean, that region, the JAK2 kinase region, whether it's a pseudokinase or the kinase, that region is extremely conserved in biology. It's very, very difficult. So I like that. But to be honest with you, the hope I have is that there is going to be some progress in acute myeloid leukemia. And then we will steal that drug and apply it to our patients with myelodysplastic syndrome or myelofibrosis. That's the hope I see. I think if there's going to be something good from the standpoint of disease modification, it's going to trickle down from acute myeloid leukemia research. I don't think the focus from the chronic myeloid group, whether it's the MDS community or the MPN community, is misdirected. The focus is palliation. How can we improve your fatigue? How can we improve your anemia? How can we make you feel better? It is not focused into how can we cure you and so forth. So the focus now, unfortunately, in both MDS, I'm not saying that targeting anemia is a bad thing. I'm not saying any of that. But if we were to actually make a difference, we have to have a stronger focus towards disease-modifying agents. Now, short of that, we have to ask, where is the unmet need now? Is the spleen really the unmet need? And by the way, do you know what the dose of the Ruxolitinib was used in the Pelabresib? It was like 10 to 15. I mean, that's for the dogs. The question, you have to, if you really want to show something valuable on top of something you already have, then you should use the maximum proper dosage. If it was me, I would use 20 to 25 milligrams twice a day of Ruxolitinib to compare the lower dose combination of Pelabresib. That's how I would have done it. So if I wanted my patient to have a smaller spleen for one reason or another, maybe the patient needs to go to transplant, and the transplant colleagues would say, well, we need a smaller spleen. Oh, by the way, I just take the spleen out. If they insist that I get rid of the spleen, I just take the spleen out. Because you can just push. There is a limit. You cannot push further. By changing this drug or that drug, it's not going to make any difference. So if I want to shrink the spleen further, I will just increase the dose. But I don't think that's the unmet need right now. The unmet need in myelofibrosis is anemia and disease-modifying agents. That's where they're needed. And for the disease-modifying agents, I told you that the acute leukemia progress in acute leukemia is probably going to trickle down. In terms of anemia, it is very vast, Ashwin. I mean, you don't want me to get me started to talk about that. I mean, you already know that erythropoietin works, correct?
Correct.
Now we have drugs, perhaps, that do not need external administration. We can induce erythropoietin production by using the so-called HIF-PHD hydroxyperoxylase inhibitors, right? So if you inhibit that with roxadustat, for example, roxadustat, you can increase the anemia through erythropoietin. Nothing different, but can it work together? And then there is that big area of the transforming growth factor superfamily tree. Okay, that big area, I've got the transforming growth factor beta ligands, all right, like activins, growth differentiation factors, TGF beta, their receptors, right? All of them, BPNP, activin receptor 1, and the enablers, hepcidin production, hemojuvenil. There are many, many targets that you can target. Luspatercept, it targets the TRAP, targets the activin receptor type 2, right? Type 2B. And then you've got sotatercept, type 2A, same ligand. And now you have the newer one, okay? I think it's KO or Eltricept. Yeah,
KR50.
Yeah. Eltricept, they're all the same. They trap, and by trapping that, they stifle the SMAD signaling pathway and affect late-stage erythropoiesis and hepcidin production. But then there's also targets at the receptor site, because these are the type 1 receptors are the ALK receptors. So now we have ALK inhibitors. You can hit ALK many ways now. We actually have a different mode of affecting the SMAD signaling pathway. We have a clinical trial here at the Mayo Clinic where we actually target the hemojuvenil, which is a co-receptor for the entire TGF beta signaling pathway. And all of these drugs give you about a 50% of response, 20 to 50% response. And they're very, very, so then the question then becomes, where do I see this going? These are all different targets. You can combine them. You can combine, for example, luspatercept with an anti-hemojuvenil antibody, with roxadustat. But then you do all that to get what? An increase in hemoglobin of 1.5 or 2, all right? That's it. That's it, period. Which means, yes, we can do that, and we can improve. We can actually at least fulfill the unmet need in anemia. But at the end of the day, we still have to find something that actually modifies the disease. I hope that answers your question.
It does. So just to close the discussion about the two clinical trials that were presented at ASH 2023, you don't see a path that these two agents will be FDA approved?
I'm happy you asked that question, because what I think has nothing to do how the FDA decides. The FDA is a very, very traditionally respected body that does things extremely carefully. They have their advisory boards and so forth and so forth, okay? I just tell you what I think.
Sure.
So you shouldn't really try to, because I don't work for the FDA. I don't work for drug companies. I try to be at arm's length from both, because I like to be independent. I don't want to be conflicted. If I would be surprised if the FDA would approve Selinexor or Navitoclax. I'll be very surprised because, number one, they're too toxic under the circumstances. If somebody's going to die tomorrow, you might accept the toxicity. But these are good-looking patients. They're not going to die tomorrow. Number one. So I really don't see a path for either Selinexor or Navitoclax to be approved. But that's me. That's me. That's me. Now, Pelabresib is again, if it was me, would I approve it? I wouldn't, because I think it's a distraction. More money. Okay, somebody's got to pay. These drugs are very, very expensive. It's like approving another TKI for CML. Okay? I mean, what is it going to do? I mean, I can do everything I can with imatinib. I don't need anything else. So the question is, if it were me, would I approve it? No, probably not, because I really don't see myself using that drug for my patients. See, for me, that's the way I answer it. Mm-hmm. If you ask me, would I approve that, then I would ask myself, would I use this in any kind of situation? I don't see myself using Pelabresib because my patients are fine and they want to test their food, okay? They don't want a 20% dysgeusia, all right? Life is short. I like to eat. I'm sure most of my patients like to eat and test their food. So the question is, why would you do that? You just want a smaller spleen? At what cost? And who's going to pay for it? And all those things come into mind. I feel that these things are a distraction. I think we should really look into drugs that actually, just wait for the AML thing. See, we're using Venetoclax, for example, in blast phase MPN, based on what the experience is in AML. Now we're using IDH inhibitors, and they work. But all these things, even in AML, they kind of work for a little bit. Yeah. You still need to transplant them anyway. So I think in overall situation, to answer your question directly, targeting anemia, I think the anemia drugs have a better chance of getting approved. The add-on, the Ruxolitinib add-ons, very tricky situation. Like I said, I don't know. If I want a smaller spleen, I'll probably increase the dose of Ruxolitinib or something rather than add another drug. I like to just use one drug if I can.
So to your point, one other thing I want to add, and which is something I've seen at the ASH presentation of Manifest 2, is that they have shown that there is some improvement in fibrosis, which we call it morphologic improvement, as well as they showed some data about improvement in cytokine levels. I'm not sure what to take from it. I'm just curious, what are your thoughts on that?
Oh dear. I don't know how to answer that, Ashwin. I don't know how to answer that. See, by nature, myelofibrosis is a cytokine storm.
Sure.
We've published this many years ago. We've shown that hepcidin is increased. We've shown that all sorts of inflammatory cytokines, by nature, anything you give to a myelofibrosis patient is going to reduce the cytokines. Anything you give, hydroxyurea, will reduce the cytokines. Anything you give, you calm it down. It's a cytokine storm, okay? All JAK inhibitors reduce the cytokine level. So reducing cytokine level basically means you're treating the disease. It doesn't really matter what it is. Now, how about the fibrosis? That is I told you about spins before, right? A decline in JAK2 allele burden, retrospective messaging of the data. And this, when it comes to this spin, the others have to take back. This is the most boldened, most outrageous spin to say fibrosis is because fibrosis is noise. Fibrosis in myelofibrosis is just part of the stromal reaction. There is angiogenesis, there is this, that. And it is patchy. It is patchy. It depends on where, you can have two bone marrows both sides and they won't have the same kind of fibrosis. Basically, what it means is that the stromal reaction, the cytokine storm, all has been calmed down. So what does that mean? It means nothing to me. I'm not interested in treating noise. I'm interested in doing the clonal nature of the disease has to be addressed. So to suggest that the fibrosis might be decreased and this and that, without an accompanying meaningful laboratory, biological, or clinical outcome, means nothing to me.
So one final question, Dr. Tefferi, and this is, for the future drug development. If today you had to design a clinical trial in MF, and FDA reached out to you and said that please give us 4 endpoints for designing a clinical trial in high-risk myelofibrosis, what would you say?
I would say, dear FDA, I'd say, please spend the money and the focus on transplant. Okay. That's the only treatment, cell therapy. Transplant is the only, I'm almost coming to 40 years in practice, okay? Disease-modifying agents in myeloid leukemias without targets, unless it's APL or COP1-defined acute leukemia, or things of that sort. Very, very difficult. And everything is a little bit incremental, a little bit of that, a little bit of that. So I'm going to say, hey, how about we focus on transplant, cell therapy-based therapy. I would say I would focus on how to broaden the availability of transplant or immune therapy. I would broaden it, immune therapy, whether it is CAR-T or whatever it is, especially allogeneic stem cell transplant. That would be my, the rest, Ashwin, you don't have to ask Dr. Tefferi. I think you can tell. You yourself know that anemia is an unmet need. You know that this, that, and you know that all the drugs don't work. You know that. You don't need Tefferi. I think if you ask me if FDA reached out to me, I would say, let's focus on transplant. Let's broaden it. Let's make it available for a lot of people. And let's do more studies with transplant, because there is conditioning. There is post-transplant modifications. You want to reduce the relapse rate, and without necessarily increasing the relapse, non-relapse mortality. See, transplant is a bifurcation. It's a bifurcation between non-relapse mortality and relapse risk. So you can try to improve upon that with conditioning, with GVH prophylaxis, maintenance after transplant, all sorts of things. So I would focus on surrounding transplant, either using it and so forth and so forth. That's what I would do. In terms of drugs, I'll just have to wait for progress in acute myeloid leukemia, as I always told you already.
Yeah, I just, we already spoke about Pelabresib, but I just wanted to ask one of the question, Dr. Tefferi, that you already mentioned, just for our audience. So the Manifest-2 was a randomized, double-blind study, as you said, and it was Pelabresib in combination with Ruxolitinib versus placebo plus Ruxolitinib. So you mentioned that the Ruxolitinib dose that was used, that was suboptimal, not the dose that you would use in your clinical practice. So does that mean that the control arm was potentially like a weak control arm, because in the control arm, the investigators were not allowed to increase the dose of Ruxolitinib to push the dose to the maximal level?
No, I think the details are a little more complicated. The initial dosing was 10 to 15 milligrams on both arms. Okay? But so what I am saying is, if I am going to use an add-on drug, okay, the 10 to 15 as the add-on for Pelabresib is fair. I have no problems here. But the other ones should have been started with a higher dose. Because seriously, whatever kind of treatment you are on, if you don't see value immediately, everything gets discouraged. The follow-up gets discouraged, and so forth and so forth. So what I would have done is I would have actually started with 20 milligram in the Ruxolitinib plus placebo arm, 20 milligram twice a day of Ruxolitinib, and the other one. Now, I understand that in both these trials, there was an increase to try to get better, and the median doses were higher. But even with the median doses, the median doses were never over 15 milligrams twice a day, okay? That was the median. So if you want a good spleen response, and if you are happy to get more cytopenia, more myelosuppression, or what have you, and you can start with 20 or 25, and you will get a fantastic spleen response. That's why fedratinib appears to be better in spleen response, because dose for dose, it is a more potent agent than either momelotinib or ruxolitinib. So that's where the question of the dosing is. Does that make any sense?
Yeah, that makes sense, definitely. So what you are saying is you would push the dose to the maximum level in clinical practice before you would even think of switching or adding an add-on agent like Pelabresib. You would rather push the dose of ruxolitinib first to the maximum possible level, right?
Raj, that is absolutely exactly what I mean. Like, for example, if I were to start with ruxolitinib, I look at the situation, you know, the platelet count, this and that, but I usually like to start at 15 twice a day. And if I am not getting the response I need, I go up to 20 or 25 very fast, because patients need the relief, whether it's symptoms or a big spleen. So you want to maximize the drug. Now, we did a study, a real-world retrospective study, and we asked the question of those patients who got switched to fedratinib from ruxolitinib, how did they respond? And it was very easy. In that study, it was very clear to show that if you switched from 20 twice a day to fedratinib, nobody responded, because you were already on a high dose. But if you were taking ruxolitinib 5 milligrams or 10 milligrams, and then you switched to fedratinib, then you responded, which tells you that you really have to maximize the single agent drug first before A, you switch the drug, and B, before you add something. So, I mean, it makes sense. You already know the drug, you have the drug, you know the side effects and what have you. And it's probably cheaper also. It's cheaper to do that rather than try to switch or to add on. Now, I want to make sure that I'm not necessarily criticizing the study design or the investigators or whatever. No. I'm just telling you my own take on these things, and especially on those two clinical trials, that there is no one is going to argue that the two drugs, even Selinexor, can produce more spleen response. The question is, A, do you need it? Do you need 5 centimeters as opposed to 10? Aren't you okay with 10? Number one. And B, if you need it, at what cost? And I'm not talking about financial here. I'm talking toxicity. All of them have. Navitoclax particularly. But Pelabresib is not without it, is it? About 20% of dysgeusia. And there is also more myelosuppression. These are good drugs. I mean, I feel sorry about it, because that's the best we can do right now. Okay, the bromodomain 4 appears to be the most appealing target right now. And by the way, it's not only Pelabresib, and everybody is doing their own BET inhibitors, many BET inhibitors, but they're going to all do the same thing. You're going to shrink the spleen more. And so what does that mean?
On one final thought, Dr. Tefferi, I know there is type 2 JAK inhibitors coming right now. They recently got IND. There is one from Ajax Therapeutics and one from Insight, which is going to be opening clinical trial very soon. So you seem to be very excited about these agents, given that...
No. You completely misread me. Completely misread. Have you ever seen me being excited about a drug? You completely misread me. I mean, I was excited about Gleevec, okay?
Sure.
I was excited about, but I think you completely misread me. No. I think it is the right direction.
Sure.
Okay? Because the direction, the scientific direction is, let's be more specific, let's get more disease modification, rather than let's just kind of calm down the cytokine storm and make the patients feel better. I like that. I like the attitude of these trials, because they're directing the science back to where it should be. So in that sense, I like that, in that sense. And who knows? maybe it will work, maybe it will work. But I'm not excited, absolutely not, because I just don't see how they're going to manage to make it specific. I mean, they saw the scientists working in there, God bless them, but that region is very hard, very hard.
Thank you so much, Dr. Tefferi, for your time. And we look forward to having you again on our podcast in the future to discuss hopefully about eosinophilia.
Absolutely. Will be my pleasure, my friend. And you guys have fun. Take care.
Thank you.
Thank you.
Bye-bye.
Bye.